Hello, it is Dr. DeShavo. We are Chapter 1, Part 4, finishing up cancer and starting genetics. We left off at a question time, and now we're starting with clinical manifestations of cancer. And this probably looks very familiar for most of you. One thing, just clinically speaking, it's been years since I've practiced, but sharing stories is always good. I had a patient years ago who presented to my office with a full body rash, and it had come out of nowhere. She hadn't been working outside, and I just had a strange feeling, and I sent her to her doctors, and she, whether this correlates or not, had lung cancer. So he seemed to think her body was reacting to it, that it had reached a point where it had spread enough that she had a reaction to it. So there's obviously more clinical manifestations than presents here. You've seen them, I'm sure, but these are good ones that we should earmark. The other thing is that sticks in my mind, if it doesn't go away, you should get it checked. You know, that nagging cough. When I had my national boards, they had a patient present with a cough when they raised their right arm, and they had an apical tumor in their lung. So, you know, if you have some weird physical presentation that is new and persistent, you should always get it checked. Can't hurt to check, right? That's my theory. Complications, you know, all side effects. I'm going to let you read through those on your own because I think those are pretty self-explanatory. Complications of cancers. Okay, now classification, tumor, node, metastasis, based on the spread of the disease. So you're going to go according to the size of the tumor, whether there's nodal involvement, and whether it has spread. And you grade it accordingly. There's, you know, variations according to where it goes. Breast cancer is the one that comes to mind that's the most well, every time you go for your breast exam, you can see the chart right there, and it lays it right out. So 1, 2, 3, and 4, and then of course as a tumor enlarges, there's more chance of it going to blood vessels. Don't forget blood vessels as well, lymph vessels, and surrounding tissues. Here's a breakdown of that tumor, node, and metastasis actual nomenclature and where I got it from. You know, T0, main tumor cannot be found. And then we've got 1 through 4 according to the size. I'm buzzing through this because it makes sense, but of course, if you have any questions, let me know. Nodes, 0, there's no cancer in the nodes. You know, 1 through 3, the amount of nodes that are involved, the higher number, obviously, the more nodes there are. And then metastasis, whether it has spread or not. Okay. And then you can grade 0 through 4. This is a great picture because it shows you 0 obviously is minimal to nothing. And then as we progress, you can see the nodal involvement are the little green circles that are above. And then if it's spread into the bloodstream, don't get confused with this picture. This shows colorectal cancer. So we're not looking into a blood vessel. We're actually looking into the colon there. And you could see that tumor expanding out into the colon, and the blood vessels are surrounding it. The colon is very vascular. There's a large blood supply that goes to and from the colon. So you could see the blue arrow represents the spread to other organs, which could, you know, be to surrounding tissues, but most likely you could get some into the bloodstream or through the lymph vessels themselves. Here's common sites of metastasis. I won't test you. I won't say this will spread to this and that will spread to this and this will spread to this. I think this is a great thing to keep. The book that we're using for this class really has some great references. I wouldn't sell it back. It's pretty cheap, and you can pop right in here and look some of these things up. I do think after all the years I've taught PATH, this is one of the best books I've ever seen. And it'll give you some good quick references should you need it. Treatment, once again, I'm buzzing through all this because I do think it's pretty straightforward. Curative, palliative, prophylactic. You know, prophylactic is where we all want to be. If you are in doubt, send them out. I didn't even mean to match words there, to rhyme there. But whenever I've had anything weird in my office, I practiced for almost 10, 15 years, however long it was. Go get it checked. Why would you not, with all the things that we have that we can test people for? Just say, hey, go get it checked. That mole looks weird. Go get it checked. You feel funny in your stomach for a long time. Go get it checked. My goodness, doctors love to test. So go get it checked out. And obviously surgery, radiation, depending on what kind of cancer it is, you have lots of different treatments. Immunotherapy, man, I think that is some promising stuff that is out there. That's very exciting. Some of the things are using immunotherapy to get our own bodies to fight off those cancers. And let's not forget holistic treatment too. I think stress, guys, is like numero uno in lowering our immune system so we can't fight off anything. This is not medical advice by any means, but looking into some of those holistic things can't hurt. As long as you're careful and you research what they are, especially coming from an herb and vitamin standpoint, you do want to make sure that there's no interactions or contraindications with herbs and vitamins. But everybody can meditate. You can meditate too, and it'll make you feel better, I promise. Here we go. Question time. Stage 4 cancer is most likely to be encapsulated, has no node involvement, has spread beyond the initial area of cancer, and has been known to cause no symptoms in a patient. So choose your best answer out of those. Genetics. Okay, moving into genetics. I'm going to put in your supplemental information a really nice video that I want you to go watch right now. I want you to pause this tape and watch this video about the basic introductions of alleles, which are the expression of our genes and how we have brown hair, blue eyes, whatever, our height, our size, whatnot. Watch that first, and then I want you to come back and watch the rest of this video. It's very short. I think it's 4 or 5 minutes, and it'll help you to understand what we're going to get into, because we're going to talk about chromosomes. Now, our chromosomes are located, it's the genetic information inside of the nucleus. When we're talking about chromosomes, basically it's long strands of DNA. It's like spaghetti. And when we're looking at a cell that is not replicating or undergoing mitosis, remember mitosis is when we replicate cells. If we were to look at the inside of the nucleus, it looks like a big bowl of spaghetti, and obviously huge amount of spaghetti to have those genes on there. When we go to replicate that cell, it forms chromosomes, and there are 46 chromosomes in 23 pairs. It's called the karyotype. I'm sure you've seen pictures of that before, and I'll actually try to remember to get a picture of a karyotype for you and put it in your supplement. Okay. And I'll put a picture of just when the DNA. So it's like if a humongous bowl of spaghetti in the nucleus. When that cell is ready to replicate, it's going to form 23 pairs of chromosomes. And on those chromosomes, they're numbered, those pairs, we find genetic information on specific chromosomes. And then, so there's 22 pairs of what are called autosomes and 1 pair of sex chromosomes, which are your XX and your XY. And we can create a karyotype, which shows where all of those chromosomes are, and that'll give us an idea of where the genetic material is that we're going to be talking about. So like I give you an example of a defect at chromosome 15. If you're looking at that karyotype, you look at chromosome 15, boom, that's where it would be. Okay. Now, a phenotype is the observable characteristics from those genes. Like I said before, height, weight, etc. And those genes can be expressed as alleles. So alleles are variations of those genes, and that's what the video talks about. So on that gene for eye color, you might have different alleles. You might have an option for brown or blue, and the one that is dominant is the one that will be expressed. unless you have two recessive. It's so confusing. I feel like I'm trying to teach you so much in just a little bit. So if you have just recessive alleles for eye color, okay, such as blue, that's what'll show up. If in your expressed genes you have a dominant, such as brown eyes, that'll show up, okay? So if you have homozygous genes that are both for blue eyes, you'll have blue eyes. If you have homozygous for brown, which are dominant, you'll have brown. But if you have heterozygous, where you have one brown and one blue, the dominant, which is brown, will show up. Okay? Does that make sense? I hope that makes sense. Okay? And it's very well explained in that short video that I give you. If it doesn't make sense, let me know. Okay? So you're going to have genes. If you have homozygous identical pairs of genes for a recessive trait, that's what'll show up. But if you have heterozygous, the dominant will show up. Okay, so hopefully that makes sense. Once again, if it doesn't make sense, shoot me an email. I'll try to explain it a little bit further. Now we're going to go, so this is, I mean, chromosomes, guys, realize, I think I'm kind of like, this is a whole class that I'm trying to summarize in one PowerPoint because I want to get right into the actual disorders, because from what I understand, that's really what you're going to need a strong background in. And as we go into the disorders, I'm going to explain a little bit of the dysfunction with the chromosomes as well. Okay, so you need to know just this basic introduction for chromosomes for this class. We're going to get into the bread and butter, which is the actual disorders. So genetic and congenital disorders, we're going to talk about a couple of congenital disorders as well. So some sort of mutation along that karyotype or those chromosomes cause a mutation in one of those chromosomes, and there's hundreds of them. And you can see them in that Punnett square. If you were to go down and show what's recessive and what's dominant and figure it out, you can figure out if someone has the 25% chance of getting it, the 50%, the 100% in some cases from that Punnett square. Okay, now there's all, with the mutation, there's also damage to some of these chromosomes that can happen, and we'll get some examples of those as well. Now, dominant disorders. So this will have a dominant gene expression, and that could be overriding somebody who has a recessive. So if you have a father who has a dominant and mother who has recessive, you'll probably have about a 25% chance or 50% chance, of getting that. And two examples that I want you to know are Marfan syndrome and neurofibromatosis. And there's hundreds, okay? These are just two examples that we're going to give you for this class. Now, Marfan syndrome, this is a connective tissue disorder. This is going to be on chromosome 15. It affects eye skeleton, cardiovascular system. They tend to be very, very thin and tall. They have what they call funnel chest. We used to call it pectus excavatum. I don't know if you've ever heard of that previously, where the sternum is very indented and pushes inward, and they have scoliosis. They can also have valve defects. Basically, anywhere there's connective tissue, they can have a defect with it, and you have connective tissue throughout your whole body. You can have lens displacement. You could have retinal displacement. You tend to be very tall. You have joint issues. You have scoliosis, valve defects, because there's actually connective tissue in the underneath the mucous membranes of the heart or the endometrium. And they tend to, I had a friend in college who had this, move very slowly because their fingers are so, when they're trying to pick things up, especially, his fingers were so long that he had to really think before he picked things up. Okay, neurofibromatosis, there's two forms that we're going to talk about. Type 1 is on chromosome 17, and this is the ones that cause the cafe au lait spots that you may have seen, and also they have subcutaneous, like little tumors. They can have nervous system tumors, freckles, scoliosis, and the subcutaneous tumors or lesions, they can be numerous. There can be a lot of them throughout their skin. They can have, over long-term effect, the cancer on those nervous system tumors that can progress as well and cause them problems. The subcutaneous lesions don't cause a lot of problems unless they get caught. You'll see, I'm going to show you a picture on, say, your clothing, okay? And then that pectus excavatum is just a huge indentation in their chest, which I don't think can cause too many problems, maybe a little bit of problem with the heart, but you can see it. It's very superficial. Now, type 2 is a defect in chromosome 22, and these cause tumors on the acoustic nerve, which can lead to deafness with them. There's not much you can do. The only treatment really is palliative removal of the superficial tumors, not the nervous ones, because you damage the nerves. Autosomal recessive disorders. I forgot to mention, we're going to go through pictures of these in a little bit, okay? So I'm not showing you pictures because I'm going to test you after. So make a mental note and don't cheat and look in your book. Okay, and we're going to try to practice looking at these a little bit. So autosomal recessive disorders are rare. They can affect both genders. You can read through the rest of that on your own. We're going to look at PKU, which I'm sure you're aware of in TAY-SACHS disease. So PKU is a mutation on chromosome 12. They cannot convert phenylalanine to tyrosine, which are both amino acids. That phenylalanine can build up in their system and cause damage in the nervous system. And you can read all the side effects of that. The real treatment is a diet low or absent with phenylalanine, which comes in, protein substances, but you can also see labels of that like on gum and whatnot. TAY-SACHS. So progressive disorder due to a mutation in chromosome 15, that's one you should know, and hexosaminidase A it's an enzyme. Whenever you look at something that has ASE at the end, it's an enzyme. And this enzyme is used to break down certain lipids so we don't have an excess amount accumulate. So if you remember way back to A&P, and if you don't, I'll explain it really quickly. On nerves, not all nerves, but many nerves, we have myelin. And myelin is a fatty encasement around nerves. That's an important structure that helps to increase the speed and transmission of nervous signal transmission. If you accumulate the wrong type of fat, even though myelin is a fat, if you accumulate the wrong type of fat and don't break it down, it can actually destroy that myelin, overtake it, and those nerves can't function as efficiently as they used to. And this can lead to all sorts of nervous system side effects, such as mental deterioration, motor function decrease, sensory decrease. Okay. Most people are of Jewish descent. There's infantile, juvenile, and adult, which is rare. This is tested for if the infant starts to show signs, if they don't suckle, if they don't have all those nervous system responses that they should at birth, they'll be tested for it. And it can progress, as you can see, and usually fatal by 5 years of age. Unfortunately, there's no cure for it. Okay, so X-linked disorders. Most sex-linked disorders are usually X-linked. I'm going to give you a few examples of this. Fragile X is one. Obviously, it's associated with the X chromosome. Most often seen in boys, can be seen in females, your book said, but mostly in males. Mental retardation, learning disability, long face, large mandible, autism spectrum disorder. I'm going to let you read through the rest of that on your own. Those bucket list kind of things, laundry list things, I'll let you read through on your own. History, physical exam, and genetic testing should they think that they have it. And the treatment is obviously supportive. You can't really fix this, unfortunately. Multifactorial, there's some other... All right, we get into some other X-linked disorders. I don't know why I jumped around here a little bit. Multifactorial inheritance disorders. There are multiples of them. And this could be environmental, it could be genetic. The one we're going to talk about, and you could read through the rest on your own, is cleft lip palate, because that's going to be one of the ones that we'll see most often in heart valve issues. But cleft lip and palate, let's talk about that. You should remember that one. If you do not have the right formation of the mouth, lips, and then it can go back through the hard palate, which is the front part of your palate, all the way to the soft palate, which is where your uvula is. And your uvula is back there to hold, to close off the nasal cavity so you don't snort your milk out your nose. Did you know that? That's what your uvula is for. The cleft lip and palate can go all the way back to there. Okay, so unilateral bilateral deformities can be from, you could see what it's from. You could see in ultrasounds, treatment would be surgery and speech therapy. And if it's not just a small amount, if it's big, it needs to be surgery pretty quickly so they can suckle, because they need to be able to drink milk, as we all know. Chromosomal disorders, oh, this is linked under here. Okay, may be related to abnormality in chromosomal number or duplication that occurs in meiosis. Okay, trisomy 21. We know this. This is Down syndrome. Increases with maternal age. I'll let you read through all of those explanations on your own. I think those are pretty self-explanatory. This I didn't know. I didn't realize that there was congenital heart defects. That they tend to have more of a chance with Alzheimer's. Percentage increase of patients have Alzheimer's. I didn't know that as well. So those may be some new things for you to know. That 4D ultrasound can help us see that. The 4D ultrasound too helps you look for spina bifida. If you don't remember what spina bifida is, it's when there's a non-union of the posterior aspect of the vertebral body. Which is a good thing to know ahead of time in case you need to have any surgery for your baby for that. Symptomatic and supportive support for Down syndrome. So Turner syndrome is deletion or all a part of the X. So this will happen in females. So they either have no second X or deletion or part of an X. So the specific gene association is not known. And they'll have gonadal streaks instead of ovaries, so they're infertile. Short statured, they tend to be a little heavier in weight. They have neck webbing. The neck webbing means that it looks like they have excess skin coming from the side of their neck down to their upper trap. They have a small lower jaw, drooping eyelids, small fingernails, widely spaced nipples. No mental retardation present, though. Okay. Trisomy X, Klinefelter's syndrome. So, one or more extra X chromosomes with the presence of a Y. So this will be in a male. Often undetected, and it presents with a slightly female appearance. Although they will be taller, they tend to have a smaller testes and penis, slight gynecomastia, slight increase in breast size, may be associated with learning disabilities, and you could read through the rest on your own on the right there. Treatment is testosterone. Okay. You can also have supermale, which is XYY, and they tend to be more aggressive, and many of them are found in jail, interestingly enough. So that's just a little sidebar. I've quickly gone through a lot of these notes because I feel like a lot of them you probably know and or make sense, but by all means, if you have questions, let me know. Let's practice for the rest of these slides. So some of these may be a little difficult to see, but I want to see if you can tell some of these genetic issues out of the ones that we have looked at. So I want you to take a minute here, 30 seconds. This may be a little difficult, but out of the ones that we've done, what do you think this might be? Fragile X, okay? Fragile X. Next one, I want you to take 30 seconds. You can also pause the tape. Yep. Marfan syndrome. This one should be pretty straightforward, this poor person. Yep. Neurofibromatosis, type 1. left palate and lip. You can see how far back that goes. And now we're going to take a guess. You probably know this one. Yep, Down syndrome. Once again, pause these. I'm going through these quickly because I expect that you're going to pause them and guess. This one's a little tough. I don't think this is the best picture in the world, but this is Turner syndrome. And last but not least, Klinefelter syndrome. And my advice is to always do these videos when you're alone and not with your children or your family. I tried to take my book the other day into the doctor's office to study while I was waiting for an appointment. And yeah, I turned right to this page. So here we are at the end of chapter 1. As always, if you have questions, shoot them on over to me. Watch these videos several times. Make sure you look at your supplemental information for additional videos and or pictures. And I hope that you have a great day. Thank you. Let me know if you have any questions. Take care.